Next one is the intrauterine contraception. So these are the devices which are placed inside the uterus, and they provide a long-term contraception that is independent of the intercourse, and they do not require regular compliance. And the duration of contraception, so they provide contraception on average about 3 to 10 years, and they can be inserted on the 4 to 5th day of the menses where the os is open, but you have to ensure that pregnancy is excluded before inserting it. If the copper IUCD is inserted in a woman that is more than 40 years of age, it can be left in place until the menopause occurs. If the hormonal IUCD is used in a woman whose age is more than 45 years, so it can be left in place until the menopause. The contraindication of the IUCD are pregnancy, previous history of pelvic inflammatory disease, there is a previous ectopic pregnancy, there is a known malformation of the uterus that is rudimentary horn, there is fibroid uterus, if there is any allergy to the kapha. And the intrauterine contraception are kappa bearing IUCDs, hormone releasing IUCDs, and the inert IUCDs. The inert IUCDs are also known as the Lepel's loop, which are absolute now. So we have already discussed the hormone releasing IUCD, that is the levonorgestrel, but the second one is the kappa bearing IUCD. So the kappa IUCD is placed inside the uterus where it acts as a parent body and induces the inflammatory reaction in the endometrium, hence prevent the implantation of the embryo, while the kappa content also inhibit the sperm motility. So the kappa induces inflammatory reaction, hence prevent the implantation of the embryo. The advantages of the kappa-bearing IUCD are they are highly effective contraceptive method that provide long-term contraception, and they are reversible, and they are independent of the intercourse. And the side effects of the copper-bearing IUCD are there is increase in the menstrual blood loss initially, there is increasing dysmenorrhea occur, and there may be IUCD expulsion occur, and there may be pregnancy occur. So if the pregnancy occur with IUCD in place, it should be removed before the 12 week of the gestation. There may be pelvic infection occur. In most of the cases, IUCD is left in place and the antibiotics are started. But if the IUCD is removed and intercourse occur, then emergency contraceptive should be used. And there are actinomyces like organism, which are the normal common cells and the cervical smear. And if there is positive ALO in asymptomatic patient, no treatment is required. But if the smear is positive and the patient is symptomatic, then we give penicillin, and we also remove the IUCD. And there is also increasing risk of the uterine perforation, which occur in 1 in a 1,000 cases. And the risk factors include if the IUCD is inserted by inexperienced clinician, or if the mother is breastfeeding where the endometrium is 10 and there are less than 6 months postpartum. Then the presentation of the patient is there is missing thread of the device on vaginal examination. Similarly, there is severe pain following insertion, and on ultrasound there will be no IUCD in the uterus. But if we do X-ray abdomen, the IUCD is found in the abdomen on X-ray. And the treatment of the uterine perforation by IUCD is laparoscopic removal of the IUCD, and if the laparoscopy fails, then we do laparotomy and we remove the IUCD. There is another term which is known as the postpartum IUCD. So these are the intrauterine devices which are inserted in the postpartum period, usually inserted after 10 minutes of the pregnancy, but they can be inserted up to 48 hours, and they can be also inserted during the C-section. Next is the relation of the IUCD and the ectopic pregnancy. So the IUCD decreases the risk of ectopic pregnancy compared to the woman who does not use contraception. However, if the pregnancy occurs with IUCD in the uterus, then the likelihood of it to be ectopic is more. Means that if IUCD is placed in the uterus and pregnancy occur, then there are high chances of the ectopic pregnancy. Next is the long-acting but reversible contraceptives. So these are the contraceptive methods that require administration less than 1 times a month, and these are the more effective contraceptive methods. And the example of long-acting reversible contraceptives include copper intrauterine devices, levonorgestrel intrauterine devices, and the progesterone-only implants, which are available in the form of subdermal implants. Next is the barrier methods of the contraception, in which the first one is male condom. So it is a barrier method of contraception, and they are most commonly used, and they are easily available, and they are cheap, and they have no systemic side effects, and they provide protection against the sexually transmitted disease and the HIV. But the disadvantage is that they are intercourse dependent, and the payload rate is high, and the sexual spontaneity is lost with the use of condom, and there is reduction of penile sensation. The next barrier method is vaginal diaphragm, and these diaphragms are placed between the posterior vaginal fornix and the pubic symphysis, and it is combined with a spermicidal agent, which hold the spermicidal jelly against the external os, and they are inserted prior to the intercourse and should not be removed less than 6 hours. And the advantages include they are in female control, and they provide protection against the sexually transmitted disease, and they can be placed and however before the intercourse, and removal may be delayed by at least 6 hours after the intercourse. But the disadvantages are they have higher payload weight, the individual petting by a trained person is required, and they are intercourse dependent, and the vaginal diaphragms are too large, they may cause urinary retention. And the last one is the spermicidal agent. So the spermicidal agent is the nonoxynol, which is a commonly used spermicidal agent, and they are not used alone because they have higher chances of failure. And similarly, a spermicidal agent that is nonoxynol, they also increases the risk of the HIV transmission. So they are not recommended for women who have high risk of HIV infection. Next one is the emergency contraceptives. Emergency contraceptives are important, and they are also known as the postcoital contraception. It is also known as the morning after pill. And the emergency contraceptives are used to avoid pregnancy after having unprotected sexual intercourse. And they are used after intercourse has taken place, but the implantation has not occurred. And the emergency contraceptives are available in two forms. The first one is the hormonal emergency contraceptives, and second one is the copper bearing IUCD. First one is the copper bearing IUCD. So copper bearing IUCD is the most effective method of emergency contraception. It is thought to inhibit the implantation if the fertilization has occurred, and they are effective up to 5 days following sexual intercourse, or up to 5 days after predicted ovulation. Let's suppose if a female has 28 days cycle, so the predicted time of ovulation is from day 14 plus 5 days, means that the chances of ovulation are from day 14 up to day 19. So they are effective if the IUCD is inserted up to day 19 after ovulation. Next one is the hormonal emergency contraceptives. So they uses the oral route, and they are less effective than copper IUCDs, and they include the levonorgestrel, which is given as a single high oral dose of the progesterone, and the second one is ulipristal acetate, which is a progesterone receptor modulator, and they are effective if taken immediately after sexual intercourse. And the levonorgestrel is effective up to 96 hours following unprotected intercourse, and the ulipristal acetate is effective up to 120 hours following unprotected intercourse. And the mechanism of action of hormonal emergency contraception is that they delay the process of ovulation. Therefore, the sperm in the reproductive tract will lose the ability to fertilize the oocyte. And there is another hormonal emergency contraceptive that include a combination of estrogen and progesterone. Estrogen is ethinyl estradiol, and the progesterone is a levonorgestrel, and they are given within the 72 hours after intercourse, and they are available in the form of two doses that are given 12 hours apart. Next, contraceptive methods are the sterilization. So, sterilization are the permanent method of contraception. They are highly effective, and they are irreversible contraceptive methods. And they are ideal for relatively older couples who are sure that they have completed their families. And sterilization is of two types. Male sterilization is known as vasectomy, and the female sterilization is known as tubal ligation. Before the tubal ligation, do pregnancies test to rule out the pregnancy. So first one is the male sterilization, which is known as vasectomy. The vasectomy involves the division of vas depends on each side to prevent the release of sperm during ejaculation, and it is usually performed via scrotal incision under local anesthesia, and it is technically an easier and quicker procedure than female sterilization. And the vasectomy differ from female sterilization in that it is not effective immediately. It requires semen analysis after 12 weeks or 3 months to see if any sperm are still present or not. And alternative contraceptives should be used until complete azoospermia. And for vasectomy, we either use diectomy or clefts that are applied to the vas depends. And the complication of the vasectomy include bleeding, wound infection, scrotal hematoma formation, sperm granuloma, anti-sperm antibodies, and the payload weight is 1 in a 2000. The second permanent sterilization method is tubal ligation, and it is a female permanent sterilization method that involves the mechanical blockage of both the fallopian tubes to prevent the sperm reaching and fertilizing the oocyte. And it can be performed via different approaches. First one is the laparoscopy. Laparoscopy is done under GA, and alternative contraceptives should be used until menstruation occurs after the procedure. Second is the laparotomy. So the tubal ligation may be done during C-section, but separate consent is needed if the tubal ligation is plain. And we have another method known as hysteroscopy. It is an option in patients who are not suitable for the surgery, and they are either severely obese or having previous multiple surgeries, and it is done as an outpatient procedure without general anesthesia, and it involves the insertion of the micro inserts into the fallopian tube, and the micro insert is quinine chemical which induces the fibrosis inside the fallopian tube. And contraceptives should be used for at least 3 months post procedure, and the contraceptives can only be stopped once the correct positioning of the micro inserts are confirmed on the x-rays. And methods of the tubal ligations include unipolar diathermy, electrocartization of the fallopian tube, the application of fallopian rings to the tube. We can also use carbon dioxide laser. There is another option known as bilateral sympingectomy and hysterectomy, which is upper only to the female patient if they have added gynecological problem, and the payload rate of the tubal ligation is 1 in a 200 cases. And the advantages of tubal ligation are it is a highly effective method that provides psychological relief from undesired pregnancy, and it is independent of intercourse, and it avoids the medical risk of reversible contraceptive methods. The disadvantages of the tubal ligation are there is increasing risk of infection during the procedure, and the payload may occur due to the spontaneous fistula formation. There may be post-tubal ligation syndrome occur, that is the increase in the menstrual bleeding after the ligation, and there may be chances of ectopic pregnancy, which is a late complication, and the high proportion of the women regret this procedure or regret the sterilization that occur in 10% of the women, and similarly it also does not provide protection against the sexually transmitted diseases. There are also certain miscellaneous techniques of the methods of the contraception, in which the first one is calendar method. In calendar method, the fertility days are calculated based on the cycle length recorded over at least 6 cycles. If a female has 28 days cycle, then refrain from the sexual intercourse for 5 days from day 8 to day 18 of the cycle. Second is the temperature method. And temperature method, there is increase in the basal body temperature produced by the rise in progesterone following ovulation. So daily temperature must be measured using the this route. The last one is the lactational amenorrhea. So, if a female having less than 6 months of postpartum and she is amenorrheic and is fully breastfeeding, then the risk of pregnancy is only 2%. But if the female having more than 6 months postpartum and is menstruating and having reduced pregnancy of breastfeeding, then another contraceptive methods should be used. So, it was all about the methods of contraception.